Hi everyone, my name is Yichen Wang. I'm currently working as a hospitalist at Mercy Medical Center, Springfield, Massachusetts. I conduct this research as an internal medicine resident at the Rice Center for Graduate Medical Education, Scranton, Pennsylvania. First, on behalf of my co-authors, I would like to thank the Gastrointestinal Endoscopy GIE for the opportunity to discuss our recently published article entitled Dieulafoy Lesion of the Upper Gastrointestinal Tract, a comprehensive nationwide database analysis. Dieulafoy lesion is used to describe the lesion of an aberrant large artery that does not undergo normal blanching within mucosal wall, resulting in bleeding. Endoscopic therapy is the first-line treatment for Dieulafoy lesion. Dieulafoy lesion is a relatively uncommon cause of upper GI bleeding. Although there are some case reports and review articles, there's no study using large database on national level to study Dieulafoy lesion bleeding in upper GI tract. For this reason, we use the National Inpatient Sample (NIS) and the National Readmission Database (NRD), the largest inpatient and readmission databases in the United States, respectively, to study the epidemiological characteristics, independent predictors of occurrence and recurrence, and outcomes of current treatment modalities in the upper GI tract Dieulafoy lesion. We compared the outcomes of upper GI bleeding between Dieulafoy lesion and other causes. We also used multivariate logistic regression to identify risk factors for readmissions of upper GI tract Dieulafoy bleeding. Our study is the first to report Dieulafoy lesion on national level. We found that 1.9% of all upper GI bleedings were caused by Dieulafoy lesion. Patients with hemorrhage from Dieulafoy lesions are older, have higher frequency of chronic kidney disease, heart failure, liver cirrhosis, and anticoagulant or antiplatelet use. Patients with Dieulafoy lesion bleeding are more likely to develop hemorrhagic shock and require endotracheal intubation compared to other upper GI bleeding. With the rate of hemostasis being 97%, endoscopic therapy is effective in treating Dieulafoy lesion. About 1.5% of patients required arterial embolization, which is both safe and effective. The inpatient mortality rate of upper GI tract Dieulafoy lesion is similar to other upper GI bleeding, but the rate of 30-day readmission and rebleeding are higher in Dieulafoy lesion. End-stage renal disease is a non-endoscopic independent predictor of readmission. In our study, we found that the in-hospital mortality rate is similar comparing Dieulafoy lesion to other causes of upper GI bleeding. However, the rebleeding rate of upper GI tract Dieulafoy lesion is almost twice as higher. We believe further studies should focus on modifiable factors associated with rebleeding, especially those are not examined in our study, such as endoscopic techniques, including injection, cauterization, bending, and clipping. We found that antiplatelet or anticoagulant use is not associated with high risk of rebleeding. This finding is possibly a result of relatively short follow-up period, which is 30 days in our study, during which time patients' anticoagulant or antiplatelet may be stopped due to recent GI bleeding. Studies of the effect of antiplatelet or anticoagulant on Dieulafoy lesion over a longer period of time may help clinicians to make decisions on this issue. Thank you for your listening, and we hope you enjoyed the article.